Good morning and welcome to today's webcast, 2020 Medicare Regulatory Update for Skilled Nursing Facilities. Before we begin, I'm going to play a brief housekeeping video.
Welcome, and thanks for joining us. We're pleased to present another in our ongoing series of continuing professional education webcasts to help companies and individuals conquer challenges as they plan for what's next. Our presentation will start in a few moments. Before we begin, here are a few things to keep in mind. You can customize how you both view our presentation and interact with the presenter. For better viewing, close all other applications and turn up your speaker volume. You can also adjust window size and placement or enter full screen mode using the controls at the top of the window or dragging the bottom right-hand corner to resize. At the bottom of your screen, you'll see a series of icons, each relating to a different aspect of our session. You can download the group attendance sheet and a PDF copy of today's slides from the slide deck and handouts widget to the right of the slide view. You can ask our presenter questions during the webcast by typing a question in the Q&A window below the slide view and clicking Submit. We'll do our best to answer all questions during the presentation or follow up via email. If you experience technical difficulty during today's presentation, refresh your browser by hitting the F5 key. Today's session will offer you 1 CPE credit. To receive credit, you must meet the requirements as specified by the National Association of State Boards of Accountancy. You must attend at least 50 minutes of the session and respond to at least 75% of the polling questions, which we'll ask throughout today's presentation. To respond to a poll, click the button next to your answer. We'll track your progress and alert you when you've earned CPE credit. You can then click the certificate icon in the CPE Progress widget to open a PDF file that you can save to your computer. Don't worry if you can't download your PDF certificate today. We'll email a copy to you in 2 weeks. If you're attending this webcast in a group, you must complete our attendance sheet to receive CPE credit. The attendance sheet is available in the slide deck and handouts widget. Please have all group members sign it and send only 1 sheet per group. Also note that CPE credit can be awarded only to participants registered as themselves and isn't available to participants who view the on-demand version. As a reminder, the presentation you're about to see isn't legal, investment, or accounting advice. We encourage you to seek the counsel of a professional service provider to apply this content to your specific circumstances.
I'm pleased to introduce today's presenter from Moss Adams, Paul Holden, partner in our healthcare consulting practice. Paul has over 15 years of healthcare experience in the areas of business assurance and reimbursement consulting. His areas of practice include providers in the acute and post-acute settings, mainly in Western states and all levels of complexity. And with that, Paul, I'll turn it over to you to get us started.
Thank you, Emily. Well, good morning, everyone. Appreciate everyone dialing in this morning or this afternoon, wherever you are. We had a chance to look over the registered attendees and see a lot of familiar names and some new ones as well. We're glad you're here. There's a lot to talk about this morning here Pacific time. The proposed rule for skilled nursing facilities was published by CMS April 25th. Lot to digest. Some reiteration of changes related to the patient-driven payment model, some additional detail on how they are going to retool and reevaluate certain areas such as group and concurrent therapy, updates on the economics of the prospective payments for SNFs, and then we're also going to talk about some other significant issues that are related to folks in this space, mainly around compliance plans, the OIG, state surveyors, and areas that folks need to be aware of heading into the end of the year, not only to make sure that reimbursement is correct, but that also you get to keep that money should regulators come in and evaluate you as well. So here are the topics for today. We are now looking into fiscal year 2020 with the patient-driven payment model effective October 1st of 2019. For this proposed rule, CMS has indicated a 2.5% market basket update, and we'll talk about how that rate is developed. That 2.5% overall equates to an increase in SNF payments of about $887 million over the next federal fiscal year. Also, we're going to see a reduction in those SNF payments from value-based purchasing of about $213.6 million. So they continue to evaluate not only the change in the cost of goods and services, but also quality of care as well as multi-factor productivity. As I mentioned, 10.1, very important that skilled nursing providers are ready for this shift. This is not so much a shift in reimbursement as it is a shift in operations and clinical performance. And we're going to talk about that quite a bit this morning. To get to this market basket adjustment, CMS actually proposed that the overall market basket adjustment from prior year will be at 3%. They also go back and they reevaluate whether or not the actual spend was in line with prior market basket adjustments. If that prior spend is not outside a certain deviation, they do not go back and make forecast corrections in the current year. So as we can see, we get to keep, at least for now, the 3% market basket update. They're not going to go back and take back money from previous years. The reason why it's important to know that CMS will go back and do a forecast error correction is that actually in the Social Security Act, when CMS was created, when all of these programs came together and prospective payments were developed in the 80s and 90s, the mandate was that these programs could not go back and retroactively recoup money. That's why they had to create bodies such as recovery audit contractors and zone program integrity contractors, because they had to have a separate body similar to the OIG that could go back and take back money that was improperly paid. When CMS makes changes to the prospective payment system, they can only do so prospectively. And that is why you'll see in DRG, APC, RUG, PDPM, any of these prospective payment systems that they have, if they made a mistake or there was an unintended consequence in rulemaking, they will make the correction in the following year. They have also decided to continue on with their multi-factor productivity adjustment, which indicates that as folks become more efficient, CMS should account for that in that market basket update. So if you are a meaningful user of electronic health records and you've reported your quality data, you will see a 2.5% increase over prior year. Skilled nursing facilities who are neither of those will see only a 0.5% increase over the prior year. Interesting to note, the previous 128% add-on for skilled nursing facility residents with AIDS has been removed, although now when the comorbidity or diagnosis is made for HIV/AIDS, that will be accounted for separately in the non-therapy ancillary and also as an add-on to the nursing component of the PDPM payment. So just to be aware that while it's not happening to the base rate, it is happening within the components of the rate going forward. And it looks like with that, we move to our first polling question. Emily?
Okay, our first polling question: do you or your team regularly review CMS's rulemaking? And your options are yes, no, or I'm not sure. And I'll give everybody a few moments to respond. To participate in our polls today, please click the button next to the answer you choose and hit submit. And if you are experiencing any difficulty seeing the polls, just try refreshing your browser. We'll give everybody a couple more seconds. And let's go ahead and take a look at the results. Paul, back to you.
Very good. Thank you, Emily. Well, about what we would expect, usually when we ask this question on various presentations, it's about a third, so pretty close to where we'd anticipate. Not necessarily historically year to year was it important for individuals in the organization to look at every single item in the rule. I would certainly encourage all on the phone that as we move into this new reimbursement model, to really keep an eye whether it's the Federal Register, rulemaking, opportunities like this through webcasts, what happens when CMS makes major changes in reimbursement methods and calculations is they do very often end up with unintended consequences. They've gone through, they used an actuary, they used a think tank, they remodeled historical claims. What is so unique about this change, though, especially for folks in the post-acute space, is that this is a change in how the data collection process is going to work when a patient is discharged from an acute care setting into a post-acute setting. How are the discharge planners handling the information on discharge? How is that information being communicated to the skilled nursing facility on admission? Did all of the surgical activity that happened, did all of the complications and comorbidity that could or could potentially occur, medication reconciliation, all of those items are going to be so important going forward on this PDPM model, and it's going to be up to the skilled nursing facility to make sure that all of that data collection is complete to the best of their ability in order to not only necessarily optimize reimbursement, but to make sure that your starting point is as accurate as possible. So not only was managing the MDS challenging previously, now we're adding a layer of almost coding, completeness, and reevaluation on top of that. So the administrative burden is high, and making sure that you are communicating that to CMS and others through your EHR, through your claims, is going to be so important going forward because CMS will continue to reevaluate that data through their rulemaking processes and adjust the PDPM going forward based on that feedback. So talking about the market basket adjustment for a minute, the important thing to discuss, and we're going to get into the wage index adjustments in just a little bit, but as a reminder, the Skilled Nursing Facility Medicare Cost Report is the only opportunity for skilled nursing facilities, whether you're part of a chain organization or you're a standalone shop. This is your ability to communicate to Medicare. This was my total spend for the year. This was the mix of my patients. And on a calculated basis, this is how much it cost my facility to take care of Medicare Part A beneficiaries. As a reminder, the Medicare cost report does not account for Part B or Part C services, but Part B and Part C can and often are a function of either consolidated billing or when the Part C plans are looking at per diem rates and other factors, oftentimes they will default to some multiple of Part A. Medicare then takes that cost report information and they feed that into their market basket calculations. And in the rules, they actually break down the importance of how these factors feed into the calculation. So for instance here, when we're talking about this mix of goods and services, we're talking about salaries, benefits, and contract labor, certain capital costs, certain supplies. Those items, CMS measures those specific baskets of goods and services over a period of time. So it is so important that even though there may not be a due to, due from in the cost report, you're communicating expense and operating factors to CMS that affect prospective rate setting going forward. So each year, start the process early, work with your revenue cycle teams, work with your finance teams, make sure that everyone, when that report goes out, is on the same page as to what your calculated per diem costs look like, what all of the other information that you put in there, especially in the wage index tables on salaries, benefits, and labor, because all of that information feeds into CMS's calculations. In the spirit of the wage index, while you go through all that effort to complete the wage index tables in the SNF Medicare cost report, Medicare has come out through rulemaking and other transmittals and said that by calculating a skilled nursing facility specific wage index would be way too administratively burdensome for their program. There are 5 times the number of skilled nursing facilities in the country that there are acute care hospitals. So what they have said is that in lieu of having a SNF-specific wage index factor, they will take the acute IPPS wage index factors for your CBSAs, whether it be urban or rural, they will take out the adjustment for the occupational mix adjustment, which is a secondary calculation that CMS uses to weight the wage index factor for certain hiring patterns within nursing categories. So for instance, in Oregon and California, oftentimes the wage index factors for the urban CBSAs, so we're talking, say in the state of Oregon, Portland, Eugene, or in California, San Francisco Bay Area, LA, San Bernardino, any of those areas, or Seattle, Washington, compared to the rural CBSAs, which encompass the outlying areas. What they say is that if hospitals hire a predominance of registered nurses compared to LPNs or medical assistants or CNAs, CMS wants to create equity in the system for those areas of the country that rely more heavily on lower cost nursing services. So they actually net down the wage index factors for those areas based on this occupational mix survey. For skilled nursing facility purposes, CMS actually takes that reduction out and uses the specific wage index factor for that location for skilled nursing facility wage index factors as well. To the detriment of skilled nursing facilities, hospitals within the inpatient prospective payment system can geographically reclassify themselves from one area to another if they meet certain threshold tests to get a higher wage index value for reimbursement purposes if they've met this certain reclassification test. Currently, skilled nursing facilities, home health, inpatient rehab, inpatient psych are actually coupled to the wage index value in their home CBSA. There is not a reclassification mechanism available to those post-acute and other providers. So it is so important that not only do you get the wage index information correct in your cost report for the market basket update, but you have to make sure that the acute providers are doing all they can to optimize their wage index value, because the trickle-down effect affects not only themselves, but all of the other providers in their community who are paid on some type of prospective payment from CMS. So something to be aware of, with all of that being said, is that CMS is seeking comments in the 2020 proposed rule from skilled nursing facilities on a better way to fairly reimburse skilled nursing facilities through this wage index factor. So when these opportunities come out, certainly with something like SNF wage index, when they have not sought comment previously, it is so important to be aware and work with your lobbying groups and other individuals who routinely submit comments to make sure that you are being properly representative and that your voice is being heard, because CMS does read these comments and very often they do act on them as well. Sometimes they'll take them into consideration for a future period, but they actually do make changes between the proposed and final rules based on how strongly and how well supported individuals' responses are. And with that, Emily, we'll move to our next polling question.
Great, thank you. Our second polling question: in the past year, has your facility reached out to acute care providers to discuss wage index trends in your marketplace? And your options are yes, no, or I'm not sure. And as a reminder, if you would like to receive CPE credit for today's webcast, you will need to respond to at least 3 of the 4 polling questions. Give everybody a few more seconds here. And let's go ahead and take a look at the results. Back to you.
Thanks, Emily. So this is about where I would have expected the results to be. Very oftentimes I get inquiries or responses from skilled nursing facilities in certain markets who really feel like they don't have control over this process. Yes, that is true. To a certain extent, you are reliant on those acute providers to make sure that their data is correct. For those individuals who are not sure, this is a great talking point. This change to PDPM opens up a very unique pathway of communication between the acute and post-acute environments. In addition to just making sure that clinical data is correct, you will notice over the past few years that when CMS is issuing their various rules, inpatient prospective payment, outpatient prospective payment, Medicare physician fee schedule, skilled nursing, ESRD, IRF, IPEF, all of these rules are proposed and finalized by CMS every year. If you read the rules simultaneously, you notice that CMS, either intentionally or just by the very nature of how close these settings are becoming, a lot of these rules are starting to mirror themselves, and they are starting to couple either payment factors or operational considerations for most of these spaces to one another. If you're not sure if individuals have reached out to acute hospitals in your area, reach out to your local lobbying groups. Certainly in various states, the long-term care lobbying groups are talking with the acute folks, whether they're at the state capitol or otherwise. So make sure that your voice is heard, because this truly affects that labor component of your payments, not only historically, but certainly into the future. As a reminder, Medicare Bad Debt is still in play. Medicare Bad Debt can be reported on the cost report if it meets one of three areas. The first one being the beneficiary had the ability to pay, they didn't qualify for charity care or financial assistance, and they don't have Medicaid as secondary. As long as you're pursuing that deductible and or coinsurance amount for 120 days or more, and it is not residing with a collection agency, that can be claimed for reimbursement as long as it was written off before the end of the cost reporting period. If a Medicare Part A beneficiary qualifies for financial assistance, if your facility offers that, once they qualify for charity care or financial assistance and it is written off as such, that can be claimed. And then the last one being is that if they have Medicare as primary and Medicaid as secondary, you can claim as soon as you receive the denial EOB from the Medicaid plan. The reason why I emphasize this each year is that in the president's budgets, whether it's been President Obama or President Trump, or even prior to President Obama, oftentimes Medicare Bad Debt has been seen as an easy line item to cut in terms of reimbursement enhancement. I think in the latter part of the Obama administration, they were proposing to reduce Medicare reimbursement for bad debt down to 25%, and I think in 1 year it may have actually been proposed at 0 as well. So while Medicare is paying for this to shore up the difference on deductibles and coinsurance, very important that you continue to reevaluate this on each of your cost reports. Getting into the patient-driven payment model, as we mentioned, this is a reimbursement change, but it is also very much an operational and clinical change. This is a move by CMS to create a variable per diem model for skilled nursing facility reimbursement. Where a lot of this, I believe, started with is that when the OIG was evaluating RUG payment rates over the last several years, they were looking at the reimbursement and the levels of RUG payments going out to providers, and then looking at the demographic information of their beneficiaries and saying, well, if we started at a certain RUG level and we have been paying you that level during the course of their stay, even if there was some change in therapy or other items, we're paying you X, but when we're looking at the demographic information, it's Y. If we're paying these dollar amounts, shouldn't our beneficiaries be getting better while they're in your facility? Now, there could be a whole host of health-related issues. You could have a certain mix in your community. You could just work in an area that has a very high acuity population. As we say in the accounting world, if it wasn't documented, it didn't happen. So as the OIG and others have been going out and evaluating this, many providers are able to support why patients are either presenting and or being discharged with certain conditions, and they support the level of RUG payment that was paid at that time. but CMS often wants to make a change because they feel like they want the outflow to be representative with the level of care provided. So this now takes the prior system of RUG-4 and moves it into a patient-driven payment model, which is specific to that patient, and it breaks down the payment factors into physical therapy, occupational therapy, speech-language pathology, and then also includes a component for nursing services, non-case mixed adjusted items, but there's also a new category known as non-therapy ancillary, and this is where facilities are going to be able to account for these complication and comorbidity items such as HIV/AIDS, COPD, diabetes. They're going to be able to capture a certain amount of reimbursement from additional factors beyond just normal ADL and therapy-related services. So this is a comparison of the proposed 2020 to the final 2019 base payment rates for these 6 components of the PDPM payment system. So you can see for both urban and rural, there was an uptick from prior year, and this is where you see that 2.5% to 3% market basket adjustment be accounted for between the 2 time periods. But you can also see what the breakdown is between those services that are therapy-focused versus those that are nursing and condition related as well. So what CMS does when they initially set these rates is they go back and they look at historical cost report and claims data in order to determine what the split should be between these various components for payment. The reason why in last year's rule CMS indicated that the PDPM shift was necessary was that they were looking at the predominance of how many times therapy services were occurring in certain RUG cases. And then when they looked at not only those rehab RUGs and looking at the ultra-high therapy RUGs, they could see that ultra-high therapy was happening a lot. And I know there's a lot of discussion and concern and confusion around the number of minutes that were recorded for therapy services, whether you employed the therapists or contracted with the therapists, whether or not it was in an individual, concurrent, or group setting. So CMS believes that by adjusting the reimbursement model to be patient-specific and focused on the individual patient's therapy needs, their complications and other conditions, the necessary and the need for a certain level of nursing services and other factors, they feel like this is going to be more patient-specific than it was under RUG-4. Now, as we know, when we went in and did the MDS, the intent was to try and make it specific to that particular patient needs. The addition of this is this variable per diem model. Under PDPM, what you are paid day 1 is not the same as you'll get paid on day 30, even if the patient's condition has not improved over that time period. So that's why that initial assessment and making sure that all of that information coming out of the acute and going into the post-acute data set is so important, is that being a variable per diem model, it's going to taper over time. Well, we want to taper from the appropriate starting point. We don't want to shortchange ourselves because then we're just going down from a lower starting point. So as you can see, there are various clinical categories and classifications that CMS is starting to bucket individuals into. Not too much time needed on this slide other than to say that because of these clinical conditions and because of that baton pass between the acute and post-acute, I have heard many skilled nursing facility chain organizations and others who have started this process early say, we never thought that we would need to hire a coder specific to acute conditions in our space because of the ICD-10 and other considerations. So folks are really taking that clinical and coding element of this very seriously because they want to make sure that they truly understand just how many complications, comorbidities, surgical items, all of these things that have happened while the patient was in that 3-day qualifying stay. They want to make sure that all of that is properly accounted for. Just a couple of other items based on some of the MDS, and then there's a link here as well to CMS's website for the PDPM specific items, as well as the mapping on those I-10 codes. So it is interesting, and this is a slide that shows the correlation between physical therapy and occupational therapy and those two therapy disciplines and speech language. It's interesting and often seen when Medicare goes back and does those forecast error projections. On the front end, they will look for correlations for how often certain services are occurring with other services and how that correlates to payment rates. They will then go back and do their review of the claims detail, and they will start to look to see if the correlations that are actually happening under the new system are representative or match up with what was happening historically. So just something to be aware of, that CMS isn't just necessarily taking these factors and loading them into certain models. They're also doing comparative and predictive analytics based on the information that they're seeing in the claims. And with that, we'll move to our next polling question, Emily.
All right, our next question. Has your facility started the planning process for the impact and operational changes required to align with the PDPM? And your options are yes, no, or I'm not sure. And for those of you that would like a copy of today's slide deck, you can download them from the folder that says Slide Deck and Handouts to the right of the slide view. We will also be sending the slides via email after the webcast. I'll give everybody a couple more seconds. And let's go ahead and take a look at the results. Paul, back to you.
Thank you, Emily. Well, we're on the clock now, friends, so I would definitely encourage those individuals who are in the no or not sure categories to definitely reach out to a subject matter expert on this. Such an important change coming up that whether you're using a point-click care or some other type of system, many of your vendors have started this process. They're beginning to reevaluate and modify modules in their systems. Some of them are doing trainings for those frontline staff. Make sure you're using your resources when and where available. This is a big change for Medicare purposes, but we have heard within the last couple of weeks that there are a lot of major payers in markets that we work with who have come to the skilled nursing facilities and outright said, we are not ready for PDPM come October 1st, and we're not sure at this point how we're going to pay you once that date becomes effective. So not only is this a change that you have to be ready for in your own shops, but there's going to be a lot of external forces pulling on you as well. So just something to be aware of and certainly be vigilant over the next couple of months. The other item I wanted to note, all of CMS's rulemaking is available on their website, and I do want to encourage that the skilled nursing facility proposed rule, easy to find on CMS's website. We're more than happy to send you a direct link to the rulemaking. It's not very long. Luckily, the skilled nursing facility rule is one of the shorter rules. It's only about 71 pages in total, but there is a table in the rule, it's table 11, and happy to follow up with folks with a snapshot of this, that actually gives a specific example of what the variable per diem reimbursement looks like over the first 30 days of a stay for a generic patient. And it's very interesting to see when they do the math that in this particular example, on day one, you're going to get 3 times your non-therapy ancillary calculated score. You're going to get the full variable per diem for your therapies. So in this example, the first daily rate in this example is $929.79. By day 30, it goes down to $631.90. So there's about a $300 difference over a 30-day stay, which is very important to note. So as we mentioned at the outset, CMS is also looking at the definition of group therapy. They have started to look at group therapy in conjunction with other payment methodologies, specifically inpatient rehab. And something to be aware of is that historically, they were looking at group therapy as for patients. Now, in the proposed rule, they are going through and actually looking at, well, how do we define group therapy in an inpatient rehab setting? In inpatient rehab, group therapy, according to the rule, can be anywhere between 2 to 6 patients at a time. And it's important to note that this is 2 to 6 patients at the same time who are performing the same or similar activities. So while CMS accepts group and concurrent therapy as an option, because they recognize that there can be economies of scale when treating more patients at the same time if it's the exact same therapy activity, they still want to make sure that group or concurrent isn't the entire type of therapy that's being performed. They do indicate in the proposed rule that when appropriate, individual therapy is still the preferred method. Also, outside of rulemaking, we were able to locate the top 5 diagnoses by ICD-10 code. So you can see in the skilled nursing facility setting, these are the top 5 diagnoses. And it is important to note that certainly with this encounter after other specified care and aftercare following joint replacement, in that PDPM model, when you are bringing in a patient who has received some type of surgical care, whether it's cardiovascular, orthopedic, those types of things, you have to make sure that those surgical procedures are being properly accounted for in that initial data set, because CMS is going to look to that to say, okay, if they had a joint replacement or multiple joint replacements and now they've been admitted to your shop and now you're performing all of these therapy-related services, is that Medicare beneficiary getting better over that period of time? Was the intent that they got the care they needed in the acute space, they came to post-acute, they received the therapy services, and now you're discharging them to home, and that clinical pathway worked as intended? CMS is really going to be bearing down on those data sets going forward. Something to note here, I know many or all on the phone are aware that in order to get the proper reimbursement in that SNF space, you have to have a 3-day qualifying stay in the acute setting. Observation currently does not qualify as the 3-day qualifying stay. And the worst part is, and there's a lot of articles out there on this, is that for those who are not fully in tune with how it works in an acute setting, you could go and visit your mom and dad or, grandfather, grandmother in the hospital. They're in a bed, they're eating meals, the nurses are coming and checking on them, they've got telemetry. Everything on the surface would appear as if they had been admitted as an inpatient. Come to find out, they get discharged, they go to the skilled nursing facility, and the family gets a $25,000 surprise bill. Legislation was proposed back in 2013 that would consider OBS care over a 3-day period to qualify, or some mix of OBS and inpatient admit. It was dying on the vine, according to GovTrack. Really wasn't going anywhere in committee, but we did notice that on March 12th of 2019, it was taken out and actually added as a secondary piece of legislation to House Resolution 1682. So at least as of this spring, this is potentially alive in committee. So we'll certainly keep folks apprised of this, because this would be a significant operating change for folks. Just a reiteration on the Meaningful Measures initiative. We've got these various factors that CMS is looking at. When we're talking about meaningful measures, they really want to focus on quality still and how that quality is being reported out. Just to be aware that you can see here on the left, we have the meaningful measures quality priority, and then the various areas within these major categories that they're looking at. And we can see certainly through these meaningful measure areas, chronic conditions, mental health, opiates. There are a lot of factors that they're looking at across this continuum to make sure that quality is being maintained at a certain level, given all of these other factors pulling on beneficiaries. So we have about 20 minutes to go in the presentation, and we want to move away from general reimbursement into compliance and what regulators are looking at. Some of these we'll spend more time on than others. You'll have all of these in the slide deck, but we really want to kind of focus in on a couple of items. Obviously, skilled nursing facility reimbursement, now that we have moved away from RUG, it won't necessarily go away. I mean, just because we're changing payment models doesn't close the door on any prior issues that the OIG or others could find in your shop. So remaining vigilant in your documentation up to September 30th and making sure that everything that was submitted can be supported by the patient's care plan, the MDS, all of that. The other item too, certainly number one here on the complaint investigation data brief, is that what the OIG often finds is that when surveyors are coming in or something is being reported, many times the loop is not being closed on those deficiencies. Something is reported, not being reported timely, being reported timely and not being followed up. Oftentimes, surveyors will come in, they'll note deficiencies, the facility will comply, they will correct, they will submit, and no one ever comes back to check. You'll see that as a common theme in the OIG's work plan. So it is so important, whether it's a survey report or whether it's your compliance plan or others, these things have to be living, breathing documents within your organization on the off chance that somebody does come back and come to follow up on that. This first bullet point here in terms of national background checks, this is so important. When you are onboarding new staff, frontline staff, nursing, dietary, administrative, you have to, through the HR process, not only check current last names, but presumed names, former names, all of those items, because the repercussions for hiring somebody on the Medicare exclusion list can be very detrimental to facilities. So as part of that process, you go through your standard background check, also check the Medicare exclusions list, make sure that wherever they have worked, whatever names they were using, that you have checked and rechecked that on the front end, because you don't want to find out about it after somebody comes in and investigates. Last year, and it continues on in the work plan, CMS continues to look at the use of opiates. They often look at not only prescription drugs, but also medical supplies, DME, all of those items. So you can see through the work plan the various items that they're looking at. They also, in addition to opiates, have continued to look at what types of drugs are being provided to those patients with certain mental illness conditions. So just more items to be aware of. Now heading into 2019, this is a significant item on the work plan to be aware of. In summary, what this work plan item is referring to is that individuals who are duly eligible for Medicare and Medicaid, they have looked at data points where individuals were either discharged from a certain setting, being paid Medicaid rates, and then readmitted to certain settings and being paid Medicare rates for a similar level of care. And so they are very interested in looking at these 5 elements, which was making sure that if it is skilled, And as a reminder, when we use the word skilled in a nursing facility setting, that is specifically a Medicare designation. If it's non-skilled, it's non-Medicare. So making sure that that skilled level of care was certified by a physician or a mid-level provider, a nurse practitioner, physician's assistant, making sure that daily skilled care was required, that the condition treated by the SNF was a condition for which the beneficiary received inpatient hospital services, or a condition that arose while they were receiving care in a SNF that required a hospital stay. So just something to be aware of, that now Medicare is not only looking at whether or not they should have paid at a certain level, but individuals who have multiple coverages or have provided or have received care provided in an assisted facility, skilled facility, inpatient, acute, they are looking at all of those various settings to make sure that the level of care equals the acuity of the patient. So in order to make sure that we meet those thresholds, we have to be careful in looking at which areas of our compliance plan we have developed, revisited, and continue to evaluate going forward. The OIG looks at compliance plans and internal controls together. You have to make sure that if you do not have sufficient controls, even if you have a compliance plan in place, the compliance plan is not doing any good. Back at the inception of the Affordable Care Act, Section 6102, CMS reiterated that the 7 elements of compliance plans needed to be there for skilled nursing facilities, and then they added an 8th element that we will talk about at the end. But to remind folks, when we're talking about a compliance plan, the compliance plan must meet these initial 7 elements. You have to have established compliance standards and procedures that are followed by the employees of the organizations and other agents that is reasonably capable of reducing the prospect of criminal, civil, and administrative violations. We know we can't completely eliminate risk, but we have to mitigate risk through our procedures. The second element being that specific individuals within high-level personnel of the organization must have been assigned overall responsibility to oversee the compliance of the organization, compliance with such standards and procedures, and have sufficient resources and authority to assure compliance with the plan. That you have used due care not to delegate that substantial authority from number 2 to individuals in the organization who knew that they should not have known through the exercise of due diligence that they could have violated any of these laws, or they could pierce the veil of the compliance plan itself. Making sure through this 4th element that you're taking steps to communicate effectively the standards and procedures to all the employees by requiring participations in training programs or by disseminating publications that explain in a practical manner what is required. Making sure that the compliance plan is a function of the onboarding. When you are doing in-service and staff trainings, the compliance plan continues to be revisited and is a living, breathing document. Making sure that you are using auditing and monitoring throughout your organization so that you understand if you're in compliance based on either ongoing or retrospective review. This 6th element, that standards must have been consistently enforced through appropriate disciplinary mechanisms, including as appropriate disciplines of individuals responsible for the failure to detect an offense. Making sure that you are holding people to account, and that once a deficiency is noted, that you are documenting that. You have to make sure that it has been documented and responded to when you find deficiencies in compliance. Similarly with number 7, obviously repayment and other follow-up, but the most important right now is this 8th element that was added through 6102. Starting November 28th, 2019, surveyors will be going out and making sure that the compliance plan was not just written and shelved, handed out in addition to the employee handbook at onboarding, and then nothing further is done. You have to make sure that you are documenting that the compliance plan, whether a surveyor comes in and talks to patient registration, your dietary staff, or the CEO, that everyone is aware of what the expectations are within the compliance of the organization. So important with this. If you have not started the process of going and reevaluating your compliance plan, we understand you're getting ready for PDPM, but make sure that you are delegating this to the appropriate individuals in your organization to start this task as well, because November 28th is not that much further than October 1st. So when we talk about auditing and monitoring, and we're talking about how do we evaluate that risk and exposure, we need to go through and do evaluations. Some of this we'll talk about a little bit more in depth than others, but really going through and doing that risk evaluation, doing a gap assessment, setting the stage. Where are we? Where should we be? And what are those risk areas that we need to be aware of? Oftentimes, folks will take a look from a risk assessment perspective and they'll say, well, there's all these things that we need to cover. Well, sometimes you just need to start with a Pareto type analysis. What are the 20% of risk areas in our organization that are creating 80% of our exposure? Let's start and tackle those first. Historically, with RUG 4, we had access to the PEPR reports, and there were areas that CMS had targeted in relation to risk areas that they felt were important through RUG 4. We anticipate that there will continue to be similar monitoring and reporting under PDPM. So just want you to be aware of those areas as it relates to PDPM. When we talk about the various elements, historically with RUG, we were looking at ultra-high therapy, we were looking at ADLs, we were looking at length of stay. On the PDPM side of the equation, when we're looking at these various components, we now need to look at that initial data set that I've been talking about. What are those non-therapy ancillary add-ons? HIV, AIDS, COPD, any of those chronic conditions, medication reconciliation, what therapy settings were involved, the patient demographics themselves. Do you have proper line of sight into who is coming in and out of your facility? What's their discharge destination? Are we making sure that they're getting into the right location post-acute? Are they going home? Are they going to home health or hospice? Being aware of where our patients ending up, and then those ongoing coding reviews. Auditing and monitoring, two different things. Auditing, retrospective review, monitoring, ongoing review. How are these two working in conjunction in your various systems? When you go through and start to do a higher assessment of your risk areas, if something potentially has come to your attention that warrants further review or potentially could involve the need for an attorney, you really should get the review performed under attorney-client privilege early enough in the process where you don't pierce the veil of that privilege so that the items that you uncover are discoverable. We are not attorneys. We encourage you to reach out to external or internal counsel, but that is one thing, as we have talked with health lawyers, that is so important, that as you go through and do risk assessments, the need to have attorney-client privilege in place can be very important, especially if you uncover something that you were not anticipating. As I mentioned, monitoring, part of your everyday process. What are those elements ongoing that we are looking at? Monitoring can be as kind of generic and specific as patient quality. Did we measure the number of falls that we had? Did we look at patient safety issues? Are we following certain processes and procedures? When we go to audit that, then we are taking all of the data that has been aggregated through that process, and we are going and doing a retrospective review. And then the most important thing is based on the results of those auditing procedures that you're following up on those items. Now going forward, there are all types of items that we can audit and monitor through this change to PDPM. There's going to be new clinical measures. There's going to be items such as, based on the care that we were providing, did we actually get all of those conditions and other elements into the initial assessment? Did the patient end up being sicker than we originally anticipated? Was that just because that happened, or did we miss something? Those are multiple areas that facilities on a go-forward basis will need to be mindful of when you're auditing and monitoring. Then you have to go in sometimes and you have to audit the auditor, making sure that you understand knowledge gaps. Make sure that the auditor is aware and being mindful of all of these different components. And then by auditing your internal auditors on this fourth bullet point, you are lending credence to their findings. You are supporting the facts that they are putting forward. Especially going forward, develop a set of warning signals. How early in the process do we need to have a check in the system to raise a red flag? Especially on number 3, and this was somewhat of more of a RUG-4 issue, and we'll see how this develops under PDPM. But what are illogical patterns that are happening? Now that we're on this variable per diem model and we are receiving less reimbursement over time, are we correlating the improvement of a patient's condition with the dollars that are coming in the door? Are those running counter to one another? Why is that happening? Did we need to go back and do a reassessment? Now, the interesting thing about PDPM, and we'll move forward to one of our polling questions here in a minute, but the interesting thing about PDPM is that there are opportunities to reassess midstream with patients, but the interesting thing is it doesn't restart the variable per diem clock. It may raise the level of reimbursement based on a development in the patient's condition, but it doesn't take you all the way back to day one. So something to be aware of, and we'll be sharing more with folks as time goes on examples of how those various changes can and should look. Making sure that you're completing a risk profile for yourself, because CMS certainly is doing so on their end. So that's something to be aware of. Also, when we're looking at legal and regulatory considerations, we want to be very aware of key TAM and other whistleblower provisions because as we make these types of changes or as we make major shifts, we don't want something like a change in operational procedure to create deficiencies that could be perceived as weaknesses in our internal controls. Also to be aware of is that with the Yates memo that came out several years ago, Sally Yates, who had worked for the U.S. Attorney's Office, had now put out there that fraud is not committed by organizations. It is committed by individuals. And you can see here on this slide that the federal government is very serious about making sure that they're not only applying those penalties and other settlements to the brick and mortar organization itself, but to the board chairs, the executive team, and others who were part of various deficiencies. Something to be aware of as well, as we head into our last polling question here, is that with these issues that CMS, OIG, the Department of Justice identify, these penalties can stack. It's not just that, well, we applied this, all of a sudden they can stack these various penalties. And the scariest thing, too, is that the government really has a profit motive in this. For every dollar that they spent on enforcement as of 2014, they had an 8-to-1 ROI on that enforcement. So they are very serious about making this a reality. And with that, Emily, we'll move to our final polling question.
Great, thank you. Our last polling question. In the past year, has your facility reviewed and/or reassessed your compliance plan? Your options are yes, no, or I'm not sure. And once you have completed all CPE requirements, you will be able to download a PDF of your CPE certificate from the CPE progress window to the right of the slide view. I'll give everyone a few more seconds on this final polling question. And let's go ahead and take a look at the results. Paul, back to you.
All right. Well, folks who are in the not sure category, let's make sure. If nothing else, let's just make sure that you have revisited the compliance plan, that you have a plan in place to go ahead and retool, revisit, update all of those items, because we want to make sure that heading into the fall, that compliance along with PDPM, along with all of the other operational and EHR considerations, this really has to be a priority. So if you task someone with this, if this is an area that you need to hire outside help to accomplish, make sure that this is one of those priorities, certainly heading into the 28th of November when the surveyors are going to be on the lookout. So amazingly, 60 minutes always goes too quickly. We could probably talk until 3 o'clock this afternoon and still be scratching the surface. But we just want to remind everybody on the line, this new reimbursement change is a reality. Here we are, it's almost August 1st. We've got about 2 months to go before go live. As a reminder, OIG is always on the lookout. They have that profit motive. I think, in recent years, I know it's gone from an 8-to-1 payoff to sometimes a 5-to-1, because I know providers have become more diligent in that. But they are out there, and they can do those takebacks and through the DOJ assess settlements. And then really making sure, I can't emphasize it enough, that compliance plan development and maintenance is a priority for all of you. We can't thank you enough for spending some time today. Everyone's time is so valuable, and there's so little of it these days. As I always remind folks, time is the one commodity you can't buy and sell. So we're always appreciative of all of you learning with us. We want to remind you and invite you to our healthcare conference coming up in November. We've got some great presenters and panelists who will be there. James Carville, Carl Rove. We're going to be doing a very unique lunch breakout session on avoiding unintended consequences and pitfalls when negotiating and evaluating Medicare managed care contracts. I'll be leading that session with my co-facilitator, Larry Vanaglia from Foley & Lardner. So we hope you can make it. Always a great time, great discussions with our point-counterpoint presenters, and oftentimes we're lucky enough where those presenters will stay after for our social hour, and you'll get to meet them in person and talk and dialogue. So we always look forward to that in early November. It'll be the 7th and 8th at Red Rock, just outside of Las Vegas. And with that, Emily, I will pass it back to you to close us out.
All right. Thank you so much, Paul, and thank you for a great presentation today. As a reminder, if you attended today's presentation in a group and would like to receive CPE credit, you must complete the group attendance sheet found in the slide deck and handouts window to the right of the slide view. If you participated as an individual and met all certification requirements, your certificate is available to download now in the CPE progress window. I'll keep the webcast console open for a few minutes to give you time to download your CPE certificate. A copy will be emailed within 2 weeks should you have any difficulty downloading it now. Here is a link to an online survey where you can provide feedback for today's presentation. Please take a moment to complete this survey, as your feedback is very important to us. Thank you for joining us, and we hope you'll join us again next time.